lifestyle change is not enough. What can we do? And I try to give you a brief overview of what's out there in terms of pharmacological approaches to target inflammation. Now, inflammation is intimately involved in all stages of atherosclerosis. I think that's quite clear. And the evidence comes from vascular biology, and I think Peter's early papers are from the mid or early 80s or something like that. So vascular biology has significantly contributed. Then from large prospective study and also proof of concept study. But the beginning or the start in terms of anti-inflammatory therapy was not really promising. If you look at this table, it gives you a number of targets that have been evaluated in the beginning, well, let's say 10, 12, 10, 13, something like that. It's oxidized LDL is secretory phospholipase, A2 it's lipoprotein associated phospholipase, A2 P-selectin, IL-1 receptor, and MAP kinase, the lost mapimode, and all of them were negative. Now this was mainly antioxidative treatment, and in addition, the methotrexate also was negative when tested in the third trial. Now I think the scenario changed when in 2013 it became evident that the NLRP3 inflammasome may play a critical role in mediating inflammation in the atherosclerosis. And the NLRP3 inflammasome is a cytosolic multiprotein complex that senses specific danger signals. You see on the left side a number of them, like crystals like microbial products, hypoxia. Peter has done some work on that, hypoxia in the plaque, disturbed pro-atherogenic flow, etc. And the NLRP3 then activates caspase, and caspase-1 transforms the pro-IL-1 beta to the active, mature IL-1 beta. That's the basic mechanism. And now the NLRP3 inflammasome can be addressed in various ways, and I go through that and give you a couple of examples of what's going on right now. I mean, obviously the first is certainly canakinumab, which was the proof of concept study published in 2017, and you can see here the MACE and MACE plus results in terms of 15% relative risk reduction, which goes along with a 30 to 40% reduction in hsCRP and IL-6, and notably there was no change in LDL. Now this 15% was about the same magnitude in terms of risk reduction as we have seen in the large PCSK9 inhibitor studies like Fourier and Odyssey. Now the effect of 15% was much larger when you looked into those who responded to canakinumab in terms of reduced C-reactive protein. And I think what you can see for two outcomes, namely cardiovascular mortality on the left side and all-cause mortality on the right side, those who responded and had C-reactive protein below 2, they had a much larger effect, namely 31%, not 15%, but 31%. The next one would be IL-6. Peter has already alluded to that. IL-1 beta, IL-6, C-reactive protein, that's the sequence what we are looking at in terms of this pathway. And there are, at the moment, no outcome studies available with IL-6 inhibitors. There are some on the way, but what is available is, for example, data with a surrogate outcome, a surrogate marker exposed to tocilizumab. And on the left side, you see different behavior of hsCRP in placebo, which is, which is here, versus the intervention. And you also see difference in terms of troponin, earlier decrease in troponin in the intervention group versus placebo. This is, more recently, siltivecimab, an IL-6 antibody, has been looked at in the rescue study, in the rescue trial. And what you see in the left upper panel is the reduction of C-reactive protein in patients with 3 different doses, 15, what is it? I think 15, 7, 15, and some more. And you see that the decrease in C-reactive protein was quite pronounced, particularly with the highest dose, and this was much higher than what we have seen in CANTOS, which was between 30 and 40%. And you see that this is a sustained decrease, as you can follow here. And and this positive result has led to a large program that's being run by Novo Nordisk. One of the studies, the first one, is SUS. It's a siltivecimab cardiovascular outcome study in patients with elevated C-reactive protein, with CKD, and with coronary artery disease. And you see they get once monthly 15 milligrams plus standard of care versus standard of care, and it's fully recruited, and it's being followed up right now. This study is also important because patients with CKD, I forgot to mention one additional criteria is the presence of CKD, because it's associated, that's what we know, with increased cardiovascular risk. But these patients are not ideal candidates for colchicine, so this different approach is very important for those. Additional trials have been started, like HERMES, which tests the siltivecimab in patients with HFpEF, and also ARTEMIS, which looks into ACS and the effect of early anti-inflammatory therapy with siltivecimab. Now the next one would be direct NLRP3 inhibitors. There are some on the way, and what they're doing, they decrease IL-6, they decrease IL-18, and they also decrease IL-1. For IL-18, I give you this data. I think I have shown some of these data already. This is hazard ratio for MACE in tertiles for both IL-18 and IL-6 before IL-1 beta treatment on the left side, and after 3 months. And what you can see, there is some decrease in terms of IL-6, not that much for IL-18. And indeed, what you can say from this data is that they support pharmacological development of therapies for atherothrombosis that target both IL-18 and IL-6, or both, such as NLRP3 inhibitors. The next one would be microtubule polymerization, one mechanism through which colchicine is effective. Partly it's also effective through the NLRP3 in inflammasome. Another important mechanism is the inhibiting of neutrophil chemotaxis, and it also interferes with the neutrophil platelet interaction. And what you can see from the first 2 studies, it's marked in yellow, it's Colcott and it's Lodoco-2, that there was a 4.2% incidence rate for MACE, in here 5.7%, so a 25% relative risk reduction in these first 2 trials published in 2019 and 2020, and the first author of that paper sits in the front row. Okay, it doesn't. Next one. Now, from the very beginning, there were concerns because in the Lodoco-2 there was some increased risk for non-cardiovascular death. It was not significant, but still 1.5, and it's if you look at the confidence intervals, 0.99. So that was of concern, and many of my colleagues from the very beginning said, well, this is too dangerous, we have to abstain from that. Now, meanwhile, there are 2 additional studies in addition to Lodoco and to Colcott that were negative or neutral. The first one is CONVINCE, and the other one is the CLEAR Synergy. And I have just a few points for CONVINCE. CONVINCE was a study in about 3,000 subjects after stroke. They were randomized in parallel group, open label. This is not a placebo-controlled trial. First composite endpoint, what you see, usually the trial was paused for 3 months in 2020, and because of COVID-19, I guess, and then was followed for slower recruitment than expected. And most importantly, the trial finished before the anticipated number of outcomes was accrued due to budgetary constraints attributable to the COVID-19 period. So this is a problem. Now, what you can see here is the Kaplan-Meier curves, and all together it was a non-significant 16% result, but you see, or you may see, some kind of initial effect in the pre-COVID-19 area, but if you go through through COVID-19, then the effect fades away. What about non-cardiovascular death? That looks better. I mean, you see we had this 1.51 hazard ratio in Lodoco 2. If you look here at non-cardiovascular death, it's much smaller, 1.10. It still goes in the wrong direction, but this is of less concern. Now, what about the CLEAR trial? The CLEAR trial is a large trial with over 7,000 patients with acute myocardial infarction referred for PCI. And the Synergy stent was recommended when available, and then they were treated in a 2x2 factorial design. On the left side, you see colchicine was split in 2 groups: spironolactone and placebo, and the other one was placebo, double placebo, and spironolactone. Now, if you look at the baseline characteristic, one important issue is that it was more or less a STEMI study, namely 95% had an ST elevation myocardial infarction and only very few non-STEMI. Now, if you look at the outcome, these are you see the hazard ratio is 0.99, so that was strongly negative. Kaplan-Meier curves completely overlap what you see here. Now, looking at the adverse effect in that study, non-cardiovascular death, again, the same endpoint as before. Now you see it reversed, 0.7 only, and 1.3% in placebo, so higher in placebo, a 29% decrease in these adverse events. So we're going from 1.51 now to 0.71. It goes in the right direction, and I think this is important because safety for such a drug is of crucial importance. And now I'm coming to the critical points. You may agree or you may not disagree, but there are a number of those. And I would say that it's just too early to condemn colchicine because there are quite a number of issues that deserve critical evaluation. I can't go through all of them, but just to mention low recruitment, modification of the protocol during the study, including large non-STEMIs with a left ventricular ejection fraction of less than 45. But if you go to the paper, you do not find those. I haven't seen what the left ventricular ejection fraction, the mean was in that population. Then hsCRP, these patients were not very well controlled with regard to anti-inflammatory therapy because on treatment in the colchicine group at 3 months, the hsCRP was still 3.0. And look at CANTOS and other trials where it was below 2. A fairly high discontinuation rate. Interim analysis showed low incidence of events. What did they do? They increased the sample size. It's also strange that in that study, compared to a number of others, colchicine had no effect on pericarditis. Incidence of gout, which is also in most instances affected positively, was not reported. They could not do control for adherence because of COVID-19. And also what I do not understand, there are so many trials, especially in particular with patients with lower ejection fraction, where spironolactone shows a positive effect. In that trial, it was neutral. So a number of issues that deserve attention, and I would not say from this study that colchicine should no longer be on the market. Now this is our meta-analysis that we published earlier this year, and you see based on the long-term evaluation of clear synergy, Lodoco, 2 COPs and Colcott, we come to 25% reduction of MACE, even larger for myocardial infarction, larger for ischemic stroke, mainly based on Colcott, on the Colcott study, and also significant reduction for urgent coronary revascularization. Now, in the same issue of the European Heart Journal, there was a second meta-analysis by D'Entremont and colleagues, and they found a 12% reduction in MACE. I'm not going into the other endpoints, 12%, but in contrast, the difference between our meta-analysis and this meta-analysis was that in the latter one, the chance 3 with 8,000 patients was included, which was neutral, and we did not include it because we were looking into long-term effects, and these patients in that trial were only followed for 90 days. Peter has already mentioned that colchicine has been approved by the FDA maybe 2 years ago or something like that, and the indications and usage are relatively wide, maybe similar to what has been said for statins, which is a bit of a surprise. In terms of what's happening in Europe, it's now in the guidelines for the management of chronic coronary syndromes, listed with the 2A indications. Low dose colchicine 0.5 milligrams should be considered to reduce myocardial infarction if everything else is on board and you still have progression. This is some kind of modeling or calculation coming from I think from the Boston area group. They looked into the potential impact of colchicine on CAD in the States based on large databases, and they come to the result that you could prevent more than 200,000 major events over a 3-year period if you would adequately prescribe colchicine in patients after myocardial infarction. Now, at the end, just 2 new indications, and I think Peter has shown one, the incretins, and this is the semaglutide study, the SELECT trial, which looked into semaglutide and cardiovascular outcomes in patients without diabetes, and you see for all different endpoints, primary cardiovascular, death with cardiovascular causes, etc., you see a clear-cut difference between the intervention and the placebo group. Now, in terms of the secondary endpoints, it's notable that high sensitive C-reactive protein was decreased by almost 40%, and if I have seen that correctly, we cannot explain it fully at the moment because part of the effect appeared before there was a significant weight loss. So there may be other mechanisms involved and cannot be solely attributed to weight loss. Finally, and I think someone else has also presented that the clear outcomes data with bempedoic acid. You see here the outcome data, and similar to what has been expected from statin studies, there is a significant decrease in C-reactive protein. Usually with statins, it's just dose dependent, and here you also see some kind of dose dependence in the order of 20 something percent. With regard to statins, I don't have to say anything. All of the statins studies that have measured the C-reactive protein, you see a dose-dependent decrease, and the mechanism may be that by inhibiting the HMG-GO reductase, statins do block production not only of cholesterol but also isoprenoids, and this results in a decrease in prenylation of small G proteins such as Rho and in turn NF-kappa B. So that's a very well-known phenomenon. Now, in summary, and I think you made some reduced some time. The inflammatory processes are present during all stages. Cantor's proof of concept trial has demonstrated that targeting inflammation without interfering the lipid metabolism can reduce important clinical endpoints. NLRP3 pathway at present seems to be the most relevant one targeting inflammation in the context of atherosclerosis. We don't know about others. We'll see in the future. And several potential therapeutic target in the NLRP3 inflammasome, including the anti-IL-6 monoclonal antibody ziltivekimab, are under investigation. And finally, treatment with colchicine, at least from my opinion, may be considered in very high patients on optimal established medication, and based on the European guidelines, it's a class 2A recommendation. So we'll see what the opinion of the group is, whether or not you can follow that argument or whether you are against that. So thank you very much for your attention.